first, I want to start that in SAARC countries, like almost of the SAARC countries, Bangladesh also, we are hugely populated country. Even our OBGYN specialists are struggling to handle with our OBGYN cases. But we all know that gynae-oncology is a very specialized service which needs trained manpower and specialized infrastructure. And it needs imaging, it needs pathology, it needs good training, and so on. Also, as adjuvant treatment, and Dr. Sudeep Gupta was telling, and we'll be listening to Supriya, we need radiation, chemotherapy, many other things. So, in this perspective, from the gynaecological perspective, I want to start with our OGSB President, Professor Ferdousi. Madam, would you like to make some bullet point comments that the challenges of country like us to struggle with facing such a huge burden of gynecological cases with our existing setup? Professor Ferdousi, madam. Are you there, madam?
She's probably in another meeting. Please.
Okay, so Koiner, madam, can you please put some light?
I am here.
Okay, madam, please. Then I will go to Professor Koiner, madam. Yes, madam. As the president of OGSB, the parent organization of our OBGYN society, you are representing the main platform of OBGYN special practitioner of our country. What is your comment about the huge burden of gynecological oncology cases in our country, and what we are struggling to face these challenges at this moment with our current setup?
Thank you so much. Basically, today I am present from the very beginning and was listening to, first of all, how this foundation has been organized, and then Shahana's presentation on our role, the young ones, especially how the present effort has been put forward so that the oncologists, gynae-oncologists, as well as general gynecologists are oriented on different issues of management of malignancies and gynecologic malignancies and their management. So that's fantastic. And finally, Dr. Neerja and Dr. Sudeep's lecture, which were really wonderful. It's fun. We are very, in February, we'll be having our conference of annual conference of OBGYN. We are hoping to take that in person, and we were planning to conduct 2 sessions. One is totally devoted to elimination of cervical cancer, and other is tips and tricks for the general gynecologist for oncosurgery. So that implies that there is a need, not only need, there is a vast need, because if we calculate that we have a cervical cancer turnover, only cervical cancer turnover in this country is about 8,000 to 10,000 per year. So it's a huge burden. And if we count our gynae-oncologists, you can count only with the fingertips. So that's give a huge need, demand, and I think gap for oncosurgeons. Not only surgery, it's radiation, referral, chemotherapy, follow-up, then palliative treatment, so much to do. So I think it's a huge burden, of course, and thank you for asking me this question. But the thing is how to solve this. We cannot have oncology it's not Aladdin's Chirag. But so what we have to do,
Madam, we will be coming about the way out on the next discussion, just the perspective. So, madam, thank you. Koiner, madam, we know, madam, that you are being an OBGYN specialist, but you are also taking active part in the leadership of GOSB, a very young society representing the Gynaecological Society of Bangladesh. And as Professor Ferdousi, madam said, that the number of qualified gynecologists are on the fingertips. But what your organization is thinking about the perspective, we are not talking about the solution. We are talking about the perspective, that what challenge that you think at present that we are facing in our country.
Yeah, thank you very much. Everybody knows we are thickly populated people. So number of malignant patients is also a huge number in our part. In a study in 2020, there is about 175,000 patients died in this COVID arena because of the shortage of treatment. So there's a very huge burden. And there is also shortage of hospital bed, then machine, manpower, then etc., etc. So we must give attention to everything. Why our patients died? Because they are ignorance about their disease process. So first they came later. They came later. They say service patient, when they come, only we can give a radiotherapy or chemotherapy. So our challenge is we must do our, Bangladesh government has doing enough for identification of these carcinoma cervix and CA breast, like via, and via covers about 70%. The HPV DNA or liquid based cytology is not feasible on our part because it is cost effective, is not cost effective. So our theme will be to make awareness of the patients, come for screening process, and if is feasible, the primary prevention should be made available so that the girls 10 to 14 years they can be vaccinated. At present, it is some lacking is there. And I have another point. All the as because expertise, manpower in this field is less. So for the time being, general ops and gynecologists who are at the peripheral level, they can give some services to this patient so that they might not, they are not come to this tertiary care, but they are not feasible to everybody to come to the tertiary care or to come to the specialist for this treatment. So in this interim period, if my gynecologist who are expert now, who have done their post-graduation, if they can give the basic services of the, or if they can then give the preliminary services for early stage cancer service or something, it will be better for the patients and also for the country. So I think this is a very important point.
Yeah, thank you, madam. I understand that in addition to the challenge mentioned by Professor Ferdousi, you are focusing on the early screening, early diagnosis and screening part, and also using the general OBGYN with such small type of training so that they can take care of the primary part, not the all part, so that the burden, the huge burden, all don't focus on our central. So now I'm moving to Dr. Rupinder. Rupinder, I know you are in a better situation like us, but not a huge better situation because you have gone through the process that we have been going. So still, at present, what are the challenges that you are facing to manage the gynaecological case in our country with your perspective? Rupinder, who is the Secretary General of AGOI, Dr. Rupinder Sekhon, and also the senior consultant from the Cancer Institute. Rupinder, are you there?
Dr. Rupinder got disconnected.
Okay, so Tom, Dr. Thomas Randall, are you there? So Tom sent me a message that he will be seeing a patient and joining to us. So, well, I think as we need to move on, so I again go back to our Professor Ferdousi Islam, madam, that what is your recommendation that what we can do?
Neerja Bhatla madam আছে তো?
Sorry, I will go to, okay, Dr. Neerja. Sorry, I missed you. Dr. Neerja is there. So can you please focus us that what is the current situation of India facing the challenge of gynecology cases, even with a slightly better position than Bangladesh, because you have a good number of gynecologists in our country, I know. Dr. Neerja.
So thank you for the question and for inviting me to the panel. So, you know, the problems I think across most LMICs are fairly similar. Large population, low doctor to patient ratio, lack of nursing and other supportive specialties, lack of access, and inequitable distribution of, services. So we have, on the one hand, a rising incidence of cancer. It's becoming a dual burden of non-communicable and communicable diseases almost. So there is a rising burden of cancers, which were also other cancers which were seldom seen before have become very common. Breast cancer has become #1 in most of the countries. Now, even the cancers which were not so common, like colon, etc., also are stepping up as the lifestyles are changing. Linked with also um, uh, with the metabolic syndrome and things like that. So a lot of these things are impacting the numbers. And many patients who live in villages and they don't have any healthcare covers, they don't have any insurance strategies. So it is causing immense financial hardship, and it is causing ruin to the families in financial terms. So in India, health is a state subject. So every state has its own practice and policy. So in some states, there is some government support for the cancer patient, but in some states, there is not. So more recently, the Prime Minister's program of PMJ, Ayushman Bharat, these have given some relief to give some support to patients who may not have the access. But still, there is a challenge on making treatments affordable. And you saw Dr. Sudeep has shown how much lacking we are in the various facilities and how much there is disparity. Yet, we have been late, I feel, in starting our trainings. Our super specialties, we have been discussing it. I saw even Dr. Elizabeth Valikad in the audience. Since 1994, I think even before, she has been trying to start the Gynae Oncology program. So a lot of efforts went into getting the medical council to accept the program and start it. But now we have started, so we should see that we get a rapid speed.
Thank you, madam. So what I understand that what you are trying, that the huge country, accessibility is the issue, lack of manpower training is the issue, and as you said that even late you have started. So I come back to our country perspective that in the discussion what came up that trained manpower is a challenge, infrastructure is a challenge, awareness and early detection could be a solution. So on these 3 points, I would like to first invite Professor Ferdousi, madam, that what action did you bullet point recommend on manpower development, infrastructure development, and awareness and early detection for this way out? Madam Ferdousi, Professor Ferdousi. So we ask Professor Koiner, madam.
So,
Madam.
So,
No, we local first.
So, as I said earlier, we must give attention to the preventive side first. Preventive side, as because many people live in the rural area, so they cannot come here to do pap smear or colposcopy or HPV DNA. So we must extend our VIA program more effectively to the hard to reach area. Number one. Number two, there must be provision for early diagnosis also, and the early diagnosis, and as because when they come to the hospital, there is a scarcity of bed and a scarcity of manpower. So government must give emphasis on the increased number of bed. Only now there is 500 to 600 bed for indoor patients, but this is the very, very insufficient in comparison to the number of patients. So the government must give attention to increase the number of hospital beds, to give more financial support to these patients, to increase the number of manpower, like they must give deputation, they must give leave for the study, so they can improve. And also also the availability of the hospital beds, and there must be a collaboration between. It is not possible on the government part to work only, so there must be a collaboration between the private and government parts, so that there is at present there are only 11 medical colleges or institutions that give service to the cancer patients, nine private institutions. So there must be collaboration, so that the patients get the services from there. And awareness program must be very meticulously, because this is the first point to make, so that the patient can be aware of the causes that causes the malignancy, like tobacco smoking, like hygiene of the reproductive maintenance, hygiene, reproductive hygiene, etc. So these are the points, and this must start from the school. I think the school health service must be emphasized to give this sort of awareness to the girls. Thank you.
Thank you, madam. Thank you, madam. I understand that you are always focusing on early diagnosis and awareness, because if we can catch it there, so we can catch it earlier, we can manage. So, Madam Ferdousi, we were talking that for a way out on manpower training, infrastructure development, and awareness and early detection. Koiner Madam was giving much emphasis on awareness. Would you like to give some focus that in our country perspective, what is your recommendation action can be taken for manpower development on gynecology and infrastructure development? Ferdousi, Madam.
First of all, I thank you for this kind of discussion, because this is important, and we basically can contribute and think about it. The first thing is, as we have discussed, that we need real oncologists. So we should look at the avenues that how we can increase that number as early as possible, because that's fundamental. As we are hopeful that we are having 8 regional centers, comprehensive regional centers soon in the country. So I think that will give us a great opportunity for developing more skilled manpower and, of course, the facilities for the treatment. But at the same time, we have to, as I was talking before, that the general gynecologists who are spreading all over the country, our almost 2,400 members of the society, should be, at least know the know-hows, and that needs training and orientation. So that's important. And also the skills, many of the surgeons are good, had good hands. So if we can teach them at least the basics, that up to this much you can treat, or incidentally, if you face these cases, then how you manage. So I think that will help, because for the time being, when we are, I think it will take a long time, since we have a very ideal system of management of oncology, we have to do this. And at the same time, we need onco surgeons as well. I mean, the radio oncologists, that has to be spreaded very soon, because there's so much need. But the thing is, as Professor Chowdhury Begum was emphasized, and the nationwide, it's not only the skill, we need to be more attentive about the preventive side. Thank you.
Thank you, madam. So what I understand that 2,400 gynecologists, OBGYN specialists can do the makeshift arrangement, with short-term training, they can take care of. Gradually, you are suggesting that transition to the trained manpower when we'll have adequate, so they will be taking care. And the day one, we cannot expect that all the qualified gynecologists will be taking the burden of such a huge thing. That is a very practical proposition. And also, as you said, we are going to expecting the functioning of 8 regional cancer centers. Definitely, this will add a big capacity. And Professor Koiner was telling that in our country, still the 60% of the bed capacity burden is now still handled by the private, but it is not accessible by the many patients. So government is the main focus. So we need to pursue the government to expand their facilities, bed capacity, so that it become more accessible. So I go to Rupinder. I think she has joined that. How you have done some transition. We heard from Dr. Neerja that how the challenges of the remote areas coming, but as a secretary of AGOI, you have seen some of the transition that you happen, you have experienced from the baseline coming to the journey. Very quick, can you give some share the experience of that, how you have done the transition from earlier to today? Rupinder.
Okay, so good evening, everyone. Actually, I was here all the time, and it took me a while to see that I have been assigned the name of Tania Ashraf, and nobody was letting me in. I kept saying, please let me.
Sorry for that. That was a technical issue. Okay. We have 30 Tanya for that technical issue.
Yeah, basically, I was noticing that there are 2 Tanias, so I was sort of surprised.
No, not at all. If you go down in the participants list, there are at least 20 Tanyas. I saw.
Yes.
So there must be some problem there. Then nothing. That's all right. That's on the lighter side. Anyhow, good evening again, and thank you so much, Dr. Kamal, Dr. Shahana. I'm so happy to be joining you all again, and I'm basically representing our president, Dr. Vijay Ahuja, So he had, I'll quickly just say a few lines that he needed to convey. He said that management of gynecological cancer, especially in LMIC, mainly depends on treatment infrastructure and resources, availability of appropriately trained manpower, socioeconomic status of the patient, and political commitment of national leaders and meaningful engagement of the stakeholders. So having said that, ideally cancer treatment should be available near the place of residence to ensure that there is proper compliance, and quality of care treatment should be ensured and offered in hospitals. So what we have done to ensure all of this is, we have collaborated, and many people have now become trained colposcopists thanks to the IFCPC. So we have, aligned with them so that at least the basic, the treatment, the see and treat should be implemented rather than the patient has to go somewhere very far and then get the treatment. That is one thing. Secondly, it would be wonderful if all the district hospitals, they had basic facilities of, say, your cobalt therapy or your basic LINIAC in terms of radiotherapy, so that the advanced cases of cervical cancer can be looked after by them right in the district hospitals. So here I want to say this, that all these newer classifications which have now been put forward by FIGO, it's very difficult, that how somebody who has got no imaging at all or just something absolutely basic, how we can, correlate them with somebody who is straight away doing a PET scan. So I'm, in my opinion, I think perhaps the former classification was better in terms of clinical staging. So that is one thing that we have to see. Then another thing is that once, the cancer is, we think of managing any kind of cancer, say ovarian cancer or cervical cancer or endometrial cancer, the basic management guidelines should be available at least in the district hospital level, so that the patient does not fault over there. And this can easily be done if we, like my former speaker had said, make all these available to each and every gynecologist and not necessarily a gynae oncologist. Then low-cost intervention like screening activities and establishment of pain care clinics should be encouraged even at district level hospitals. So all of this, if it is done, we will definitely work towards elimination of cervical cancer and so on. And as far as ovarian cancer is concerned, again, neoadjuvant chemotherapy, it should be encouraged. So that if everybody realizes that giving NACT is, in terms of OS and PFS, is the same as doing upfront surgery, then, and that NACT is available at a much lower level, say even at district hospitals. Whereas how Dr. Sudeep Gupta put it very nicely, surgical expertise is available only in very few centers. So let us look at the whole thing in a wider perspective. So that is, these are a few of my thoughts shared by the president of ECOI.
Thank you. Thank you, Rupinder. I understand that you are focusing that rather than centralized service, we should disseminate, and at the district level, we will try to increase the capacity so that we can really take care at that level. And the a very important point you have raised, that if we can disseminate the guidelines so that we all talk in the same language, we talk in the same wavelength, that is very important. Yes. So absolutely. The guideline will be a very important thing. So I go to the next slide. So from all the discussion, it comes that we cannot go alone. Now we are in a global village. Nobody can move alone. And the COVID has taught us that we can really help each other very easily with the collaborative thing. So can we start asking that if from our local country perspective, Kohinoor Madam and Ferdousi Madam, what is your thought about the collaboration at regional and international? So what is yes, Dr. Sudeep is there. If available, I would like to request Dr. Sudeep here, because everybody was giving the reference of Dr. Sudeep's presentation, and he is an ideal person to talk about our regional challenges. So Dr. Sudeep, are you still there?
Yes, Dr. Kamaluddin, I'm very much there and I'm listening. Can you please repeat your question quickly? I'm so sorry.
So I was just coming almost the last part of the discussion. Everybody was referring that the country like us, we need to, rather than focusing on centralized treatment, we need to improve the regional centers capacity. And we don't have many gynecologists, so we need to train up our gynecologists so that the basic they can take care, and we need to disseminate, train them in a short course, short time basis, and give them the guideline so that they really that follow. So now I coming back to the collaboration part. So I was going to start with our country, then I will coming back to you, Madam Koiner, Madam. That what is your thought about the regional international collaboration to overcome from this current situation? Because we need to come out from there, but as today in this world, we cannot go alone.
So
Madam.
I just want, sorry.
Yes, yes.
I thought,
so we start with our country, then I will come to you, Dr. Sudeep.
Okay.
So thank you very much. As because we have already mentioned the burden of the patients, scarcity of our trained manpower, So it is a very good option to have exchange of our training programs or in collaboration with other countries like our neighboring country, because they're doing well in comparison to ours. So the specialists, they have training facilities there, but for the general OBGYN, how much training they need, how much they will do, how can they do the primary surgery if they can be given training for 6 months or some 1 year training. So I think the basic service they can provide to the lower level facilities like district hospital, like some very private medical colleges. So it is a very good option. It will be a good option if we extend our collaboration of the training of the manpower and also the technologies also, manpower of the technologies also. So what the low cost effective treatment we can give in our patients, so that in a small amount of money we can give better service to much number of people. Thank you very much.
Thank you, Madam. Now, Dr. Sudeep, we need collaboration for training of manpower, and also we need, this customized solution for our country, not a high cost thing, but what we can do for our country, from our country perspective. Dr. Sudeep.
So I think from the gynae oncology perspective, I would like to say that there are a few initiatives, for example, from Tata Memorial Center, and some of you might have heard of this grid called the National Cancer Grid. So there are more than 200 hospitals and other organizations within India that are a part of this. And there are regular tumor boards, multidisciplinary discussions, collaborative research projects, and many other activities, including now, there's going to be a common electronic medical record, etc., and so on. So I think, we can collaborate with each other. I think one is to form a network within both India as well as in Bangladesh and between the two countries, so that training can be undertaken. So training can be of two kinds. One, I think something that is doable, and COVID has taught us that we can regularly conduct multidisciplinary tumor boards. I want to congratulate you on this, on organizing this meeting. My own sense is that if we were to conduct some multidisciplinary tumor boards with actual cases, with actual clinical discussions with our trainees and with our faculty members, I think we'll learn a lot from each other. The second thing is that India now has several centers where we have MCH in gynae oncology. And you might know about it. AIMS has it, Tata Memorial Center has it, many other centers have it. So I think there can be some memoranda of understanding between centers in Bangladesh and in India to systematically and formally train some individuals from Bangladesh who come here, and also reciprocally some individuals from India who go there to have some experience. And I think this will go a long way to cement our collaboration with each other, and also provide real, actual hands-on training to some individuals. And the third and the last part that I wish to say is that, we keep recapitulating Western data that has been generated in Western countries, in some parts of Japan and other Southeast Asian countries, but there is hardly any data from South Asia. And the few studies from Tata Memorial that I showed are still too few. We could have done more, and I'm sure all of us could have done more. So I think, I have said this to my colleagues from the Association of Gynaecologists of India, that, aside from forming, our own professional societies, we should form research network. We should have, let us say 15 centers. And even if the starting point is, let us say, systematic and uniform data collection, that will still be worth its weight in gold. So, we can, for example, form a prospective registry of patients with cervix cancer in defined centers in Bangladesh and collaborating centers in India, and pool our data together. And that can lead to further diagnostic and therapeutic studies in the future, interventional studies in the future. So I think all of these are some of the ideas. I know it is easy for me to say here. It is very difficult to implement many of these things, but those are some of my thoughts that I think could possibly be implemented.
Thank you, Dr. Sudeep. Just for your information, you were not aware, but some of your colleague has already done the magic. Last 1.5 years, Shahana is having every alternative week tumor board with live cases where our regular faculties from India was Amita, Rupinder, and so many on. So they were really enlightening us with live cases. And if you gather, I think the case number will be more than few hundreds. So this already has been done, and I really welcome the proposal that some of us, our gynecologists, can go for MCH program in different centers. And the last part is very encouraging, that I totally agree that this, say for example, this NACT trial that you have conducted, your team has conducted, has changed it is a practice changing paper. So I think we are sitting on tons of patients' data. If we collaborate country to country, we can have a better data. Like Jyoti started on breast cancer, I'm sure we can start on cervical cancer and so on. And I can see the huge prospect of that. And I really appreciate the thoughts that you have proposed. Thank you, Dr. Sudeep, for giving your thoughts. Now I asked Rupinder
Thank you very much.
from Agoy. What is,
Randall is
yes.
there. Kamal bhai,
No,
Randall
we will come to Dr. Top. So Agoy, Rupinder is there. So what is your thought about the collaboration, Rupinder? Personally, Dr. Ahuja and Rupinder, all of you are doing, but as a society, what is your thought about collaborating Agoy as a society for development of country like us?
No, we would be very happy to collaborate with you, and we have been collaborating in terms of, I think both of us have been attending a lot of your tumor boards, and we're very
Yes.
happy to. In fact, we too have been enlightened. It's not really that, because everything used to get discussed threadbare in all these meetings. So we are very happy to do that, and we would be very happy to take on some of our Bangladeshi colleagues, if they could come over to our place for, say, observership or whatever else, for extended period of time, and it would be a two-way learning. So we're quite happy to do that. And we're also happy to associate with you as an organization to discuss tumor boards, which is especially to, discuss live cases, so that, we are able to come to some kind of an agreement on the management as per the resources available in your country as well as ours.
Thank you, Rupinder. We really appreciate the proposal. And we, as I mentioned, we are really grateful to the leadership of AGOI. Most of the leaders like President-elect, Secretary, everybody was supporting. But this is an addition that as a society, AGOI is ready to collaborate. We are really happy. Thanks in advance. So I know Neerja is a very strong person in FIGO. FIGO is a bit different type of organization, but still, we don't want to keep any stone untouched. So Neerja, is there any possibility of supporters getting some support from FIGO?
So yes, at the outset, I have to say I'm now a past president, and Jonathan Berwick from Stanford is the president, very supportive. And even more support, I would say, is from Professor Mary Ann Lumsden, the current CEO, who is extremely supportive of all kinds of proposals pertaining to the LMICs. And recently we had a call for projects also. The FIGO cervical cancer prevention projects, which were aligned with the WHO call for elimination, and to show any aspect of strengthening that call and how we can, show implementation. It was a competitive call and there were 4 proposals selected. So that type of situation comes along once in a while. What is important is also that FIGO has this, which has not happened because of COVID, but FIGO also has opportunities for training prior to every conference. So before every conference, there is an opportunity to go to that country which is hosting the FIGO meeting on a traveling fellowship and to spend some time, 3 to 4 weeks, in some of the center over there. And there are also some fellowships which are there for the young gynae oncologist who can apply for that fellowship, and they can obtain some live experience, which is not a hands-on training as such, but it is there that they can do that. I wanted to add to the question of the MCH, which I wanted to tell you that we do have sponsored seats for sponsored candidates in AIMS, for example, for MCH, and those seats are available to foreign nationals as well. And those who are interested should look out for our advertisement for the exam, because they have to clear the theory exam and then they are eligible for that one as well. And I also wanted to say that with respect to FOGSI also, we have considerable effort being put into training for gynae oncology from there as well. And the Indian College of ONG, ICOG, has also been conducting some courses for updating gynecologists in the gynae oncology skills, and also trying to arrange some kind of observerships and trainings. And that observership option is available also in our institute. If somebody doesn't want to do a full-fledged 3-year MCH, just want to come as a short-term observer, that option is also there if they are not looking for a certification, but they are only looking for a experience live to see exactly how the clinics are run, how the operations are being done, and all that. Hands-on experience depends upon their license.
Yep. So thank you, Dr. Neerja. I'm sorry, because it's awesome that there are so many opportunities under the platform of not only FIGO, but also from the Indian continent. And some of our colleagues already enjoyed it, but I'm sure many of the prospective candidates are attending this program, and they will be excited to listen to you and Dr. Sudeep Gupta about the opportunity, and definitely they will grab it. So finally, I come to the last, but not the least, Dr. Thomas Randall, who is a good friend of us from Boston, and he is representing IGCS. Today we heard from the president of IGCS about so many encouraging things, but I want to hear from Tom that what is your thought about the collaboration which can create an impact of a country like Bangladesh coming out from the current situation, struggling to face the huge challenges with a very minimum trained manpower and very limited resources structure. So Tom.
So Kamal, you would be disappointed if I didn't quote 2 giant historical figures to start my comments, and I promise to keep them brief. But one is, as Confucius apparently said, the journey of 1,000 miles begins with a single step, and I want to give you all credit for taking the single step in the Oncology Club. And also for taking that single step and not becoming overwhelmed with the massive scale of the needs in Bangladesh and in the subcontinent overall. So that I think one step at a time is the right approach. And I want to particularly you and Shahana, I want to praise you for this collaborative, patient-centered, and evidence-based approach to improving these women's care. I do have some concern that this, that my second quote is Sir William Osler, who is one of the founding physicians at Johns Hopkins in Baltimore in the US and a great Canadian physician, who said to study patients without books is to sail an uncharted sea, but to study books without patients is never to go to sea at all. And so I think that one of the things we've learned from the mentorship and training program that Dr. Coleman so nicely presented was the value of hands-on training and accountability, and that these things can be done highly effectively in very low resource settings. So lower resource settings with less infrastructure than I have seen personally in Bangladesh. And so I think start small, but I think don't lose sight of hands-on training and practical training. And Dr. Sandeep very nicely put it in presenting, I think, what I think of as one of the great clinical trials of modern GYN oncology, the Tata Memorial Study of neoadjuvant chemotherapy versus primary chemoradiotherapy for locally advanced cervical cancer. And first of all, look at the value of that, as he says, having done it in South Asia. But I think he makes two very important points about that study. The first is that although the survival was not as good, the progression-free survival, it does show that neoadjuvant chemotherapy followed by radical surgery is feasible and safe in India. Tata is not a low resource setting, so let's not decide that. The second thing, however, is that we need to remember that those are highly skilled physicians with abundant, probably some of the greatest hands-on experience in the world, highest volume, most skilled. And so I want to caution the group away from studying books without patients. And I don't presume to give advice about how this should be implemented in Bangladesh. That is up to you and your colleagues. But I do think that we have models. My last word would be I'd like to exhort the listeners to look at the article by Dr. Somashekhar and some of my IGCS colleagues in this year's FIGO Cancer Bulletin on alternative methods of training for gynae-oncology. And we talk about the IGCS initiative and several initiatives in India that have been highly effective. And I think that that is a good guide for people to consider moving forward. And so with that, I'll conclude and get back to seeing patients in the blizzard of snow we have in Boston. And again, thank you all so much for your fantastic work in the Oncology Club and overall in general. We at the IGCS are very excited to see the work you're doing and to build our collaborations further.
Thank you, Tom. So I'm almost at the end of the discussion. Thanks to all the panelists. So what we learned that nothing is impossible. As Tom said, let me start with Tom's word. We need to take one step to go for take a big journey. So we have started the journey, and everybody start like this. Nobody reached this position in one day. And we are so happy to have so many friends around the globe, not only the region, but for the extra region. Already they are very much supportive, and with their support, we came a long way, and now we are feeling more encouraged to go a longer way. And the most important thing I learned from the discussion during the collaboration is that if somebody goes overseas, fine, but to get the training at home with the support, it's a mixture of home and abroad will be the best thing, because working in Tom's center, coming back to Bangladesh feeling helpless will be disastrous, rather than getting some idea and then get trained in our home environment is very important. Because there is a story in, I want to finish with a story that somebody wanted to cover the whole art to get rid of mud, but then one cobbler said that why to cover the art rather than you cover your feet, that will save you. So that is the customization. So we need to customize the solution of our problem, not to cover the whole art, not to take a big journey, rather we can do it in our own center or regional center, definitely with the help of friends like Tom or Dr. Coleman. So we are so happy to, I'm so happy for all our panelists, because this type of half an hour discussion cannot solve a problem, but give people thoughts, fruit for thoughts, that how we can move forward, and also encouragement. And I'm sure so many of the juniors will be looking for the possibilities of getting the opportunities of FIGO, UICC, and also the MCH program and observership program. Thanks to all my great panelists, and thanks to Shahana and your team for giving me the opportunity. Thank you very much. Here I end the discussion. Thank you.